Actually, this is the updated presentation from last year, so I just wanted to present what has been changed a little bit. We have HIV prevalence of the same, 0.1%, with more or less 1,200 infected cases yearly, and this is stable. HBV is stable as well, 2 to 4% of the population has HBV, with not so much of an acute population, acute HBV because of a rollout of a vaccination program, which is population-based, and every newborn from 1993 has received Hep B vaccine. HCV estimates are becoming a little bit more precise every year, so now we calculate that approximately 0.5, 0.6% of the population would have HCV RNA positive with chronic infection, which translates into 160 to 200,000 of cases. Among HIV, HBV co-infected people, approximately 40% would be anti-HBC positive, but HBV DNA would be very, very rare. And 33% of people living with HIV would have co-infection with Hep C. However, in the recent trends, we see that there is not so much co-infection, and there are co-infections in people in MSMs, which will be presented in a second. So officially, there is still increasing curve, and there is uncontrolled MSM epidemics in Poland, which we are very worried about. And if we look at the official data about the records, there is almost 30% of unknown transmission route, and this probably would be MSM epidemics, and this is reporting issue because there is difference between official report and what we see in the clinics, so probably this would be totally different picture if the reporting issue would be resolved. In terms of HCV co-infections, so as I said, approximately 160,000 to 200,000 would be estimated to be actively infected with Hep C. Fraction diagnosed at the moment is calculated to be approximately 10%, so there is still a long way to go here. In terms of subtypes for HIV, there has been no new data released yet, but what we see recently is the predominance of the subtype B, and this will be like this in over 215, 216. In HIV, there is still a little bit of import of A1, usually from Eastern Europe with immigration. We could see that there is some increase in A1 genotypes. DCs, all these are travel related, so they are still there. In terms of Hep C, as in most of the countries, genotype 1 predominates. There is a huge predomination of genotype 1b with a little bit of 1a, and the 4 and the 3 is mostly in injection drug users. So this is like was said before for the different countries. In terms of HIV subtypes, there is also huge regional variability, with western part of Poland and northern having a little bit more of immigration and a little bit of more transmissions of non-B subtypes, which are seen here in this salmon color probably. And this is related to the port city, so there is a little bit more variability to the north and to the south. But generally, the subtype B would predominate over the most of the cities. In terms of risk factors, as I said, MSM epidemics is uncontrolled, and I will show these slides in a second. HBV probably mostly sexually transmitted, a little bit of IDUs, and HCV transmissions are mostly nosocomial, up to 80%. Blood transfusion prior to 1992, when the testing was not rolled out, and now increasing in MSMs, but the reports have yet to be published for the national cohort, so we could see that over the clinics and reported over the sites, but the official report is not there. We could also see the transmission networks among subtype B MSM, and that HIV is now transmitted over various cities, and we have been tracing this transmission dynamics, and there is a huge amount of movement over the large cities and between the centers, and we could link these people molecularly, including transmissions of mutations. So there have been transmitted mutations between the cities. So this is the city, which is PN, which is for Poznan, VR for Wrocław. So large cities transmit even drug-resistant viruses, and this is only men who have sex with men transmitted issues. Also, the uncontrolled epidemics with HIV among MSM has been modeled in the molecular clock. So we could see that majority of these transmissions are early, within 2 years of infection of an index case. So the testing is necessary, early treatment is necessary, and Poland is typically the country where people still come into the clinic in the delayed phase, so in more advanced HIV more advanced HIV infection. There have been also been clusters of HCV co-infection in HIV HCV co-infected MSM, including this cluster of mutation Q80K, and this is the cluster of sexually transmitted MSM with first HIV acquired and then Hep C, so it clusters together and we could trace it as well. As for the treatment, in Poland, all the antiretrovirals except for TAF-based have been available, so this is the first time where we have a little bit of a delay in the access to the newest antiretrovirals. The new antiretrovirals have been subject to the assessment of technology, which is for the first time done in Poland. Prior, it was basically after half a year from registration, we have full drug availability. Now there is a tiny bit of a delay. We are still waiting for that. For HBV, everything is available, what could be available. In terms of HIV treatment efficacy, we have over the 90% efficacy across various regimens. It varies a little bit. This data will be presented in Glasgow, so if you would like it in the more detail, please look at this poster. I invite everybody to do so. If we assess the viremia of less than 200, it's even 96%, so it's quite a good treatment efficacy. Stable drug resistant over various cohorts, less than 10%, and we could also see a bit of transmitted integrase resistance in the northern region, which would be E107Q, so this is a huge cluster, probably the largest in Europe reported so far. Real-PV resistance is is not that important, but it's still 5% of the cases. In terms of Hep B, there is not real data on the treatment efficacy, but approximately 90% treatment efficacy is expected over the cohort. And in terms of HCV treatment availability, there has been a huge change since the last year because these DAAs have been implemented into the practice. So we have 3D, we have asunaprevir with daclatasvir, which is a rarity only for subtype 1B. We have sofosbuvir, ledipasvir for 1A and 1B, and still for genotype 3 interferon-based treatments. And the treatment is now focused on the advanced fibrosis stages, so F4 and F3, which are prioritized over the waiting lists. Approximately 9,000 people are waiting for the Hep C treatment at the moment, and it's being rolled out from approximately 3,000 people are being treated every year. In terms of HIV treatment, treatment is available for all Polish citizens, regardless the status of insurance, and also for all the people who have legal immigration status into Poland. And we have implemented the treat all principle, so basically we treat everybody who is coming into the clinic, probably with the exception of elite controllers who simply do not wish to be treated, but still most of the clinicians try to induce even elite controllers for the treatment, mostly for the epidemiological reasons perhaps as well. So, as I said, approximately 3,000 people receive the therapy for Hep C, with hepatoma incidence being stable and 68% attributed to HCV. We perform approximately 300 liver transplants per year, 100 of these being Hep C related, and the treatment efficacy in the first Polish studies for DAAs is around 98-100% depending on the subgroup, so it's really good as expected. So I hope Hep C would be treated in the near future. There is also a disparity in the survival of HIV and HCV, HIV mono-infected and HIV-HCV co-infected people, and this difference that we see is approximately 17 years of a difference, but HIV is not prioritized for Hep C treatment yet. First, other priorities are based on the fibrosis scale. So, as I said, HIV dynamics, especially in MSM, is there. There is no PrEP introduction likely in the current political setting, so maybe it would be necessary, but I don't see the option for that. TAF-based regimens are yet to be added, and Hep C, there is a DAA treatment rolled out, and hopefully it will be like that in the future. So thank you very much.